Welcome to the Deep Dive. Our mission is always to deliver a focused shortcut to being expertly informed, especially when you're staring down a complex stack of material.
And today, we are really taking on a beast.
We certainly are. We're doing a high-speed, but hopefully very comprehensive deep dive through a huge unit of medical surgical nursing. We're going to span the spectrum from pain perception and fluid dynamics, all the way to shock, cancer care, and even the ethics of end-of-life support.
You know, this unit, it really is the clinical core of modern nursing. It's a gauntlet, truly, because it forces you to think beyond just one condition and see the patient as this complex web of interconnected systems.
A web is a great way to put it.
And our theme today is pretty simple, but so critical. Understanding these systems and mastering the evidence-based care that's needed across a patient's entire journey, from, that first moment of stabilization all the way to ensuring comfort and dignity.
So if you're looking to really nail these concepts and build a framework that sticks, you are absolutely in the right place. Let's jump right in. We're starting with a topic that touches every single patient, every single day. Pain management.
The foundation of everything, really.
So let's start with the language of pain. Getting the definitions right seems like the first step. Let's lock down three crucial terms: acute pain, breakthrough pain, and the one that always sounds so strange, allodynia.
Right. So acute pain is the one we all think of. It's the body's warning system. It comes from tissue damage. It's sudden. And this is key. It goes away as the body heals. It's protective.
A functional pain.
Exactly. But breakthrough pain is different. It's a temporary, often really severe spike in pain that just flares up even when a patient's, their chronic pain is otherwise pretty well managed with their regular meds.
So they need something extra right then and there.
Immediately. Usually a rapid onset medication to get on top of it quickly.
And then there's allodynia. That term always suggests that the nervous system itself is kind of misfiring.
That's precisely what it is. Allodynia is pain from a stimulus that shouldn't be painful at all. Things like the light touch of bed sheets or even a cool breeze on the skin.
Wow.
It happens because of nerve injury, either peripheral or central. The nerves get damaged, their firing threshold just plummets. And so normal sensory signals get scrambled and sent down the pain pathways instead. It's a real hallmark of neuropathic pain.
So why does getting this right matter so much beyond the obvious suffering? The sources are really clear. Unmanaged pain isn't harmless. It sets off this whole systemic response that can really endanger the patient.
Oh, absolutely. It's a cascade. When pain is out of control, the body gets stuck in a stress response. It's just pumping out catecholamines, cortisol, all these inflammatory mediators.
And that just hammers every system in the body.
It's like a sledgehammer, yeah. It delays healing and definitely increases morbidity.
So if we look at the consequences, the cardiovascular system gets hit immediately. We see, high blood pressure, fast heart rate?
And a huge increase in cardiac workload. The heart is working so much harder, using up more oxygen.
Which is dangerous on its own, but then there's the blood itself.
Right. That stress response creates a state of hypercoagulation. The blood actually gets thicker, more viscous, and that puts the patient at a much higher risk for deep vein thrombosis, or DVT.
A major post-op complication.
Huge. And it's so often rooted in poor pain control and the fact that the patient isn't moving because it hurts too much.
And then there's the respiratory cost.
Yeah.
You see patients splinting, right? They take these tiny, shallow breaths, because a deep breath is just agony.
And that shallow breathing is a direct line to respiratory compromise. You get decreased air volumes, which leads to microtelectasis. Little parts of the lung just collapse.
As the gas exchange is shot.
It's impaired, yeah. You get shunting, hypoxemia, and because they can't cough effectively, secretions build up. And that's a perfect setup for pneumonia.
And what about the long-term damage to the nervous system itself?
The cognitive hit is significant. You see confusion, sometimes delirium, especially in older adults. But the most insidious thing is that unmanaged acute pain can actually remodel the nervous system. It can hardwire it, making that patient incredibly vulnerable to developing a chronic, intractable pain syndrome down the road.
Which brings us to a huge challenge. Pain is subjective. So what happens when your patient can't tell you they're in pain?
This is so critical. The golden rule is pain is what the patient says it is, but we also have to remember that the absence of a behavior like a grimace does not mean the absence of pain.
So you can't prove it's not there?
You can't, and you have to assume it could be, especially in patients who are intubated or have advanced dementia. That's why we rely on the hierarchy of pain measures.
Okay, so this hierarchy gives us a systematic path to follow. Walk us through it.
So you always start by trying to get a self-report. Use pictures, whiteboards, anything. If that's impossible, your next step is to look for painful conditions. Is the patient post-op? Do they have a fracture? If you'd expect pain, assume it's there. Third is observing their behavior but using validated tools. Fourth is getting reports from family or caregivers who know the patient's baseline. And then finally, if you still suspect pain, you can move to a very careful, monitored analgesic trial.
What are some of those specific observational tools you mentioned?
For adults with advanced dementia, the go-to is the PAINAD scale. It standardizes how you look at things like their breathing, any negative sounds they're making, facial expression, body language.
And for the ICU?
In critical care, especially for an intubated patient, you'd use the CPOT, the Critical Care Pain Observation Tool. It's great because it includes things like muscle tension and whether they're fighting the ventilator, which can be a huge sign of pain.
All right, so moving on to treatment. The big paradigm shift is the multimodal approach. Why is using a cocktail of drugs so much better than just relying on one?
It's all about synergy and lowering doses. You combine drugs with different mechanisms, an opioid, a non-opioid like an NSAID, and a co-analgesic. By attacking pain from multiple angles, you get better pain relief with a much lower dose of any one drug.
Especially the opioids.
Especially the opioids, it's all about minimizing those side effects.
Okay, let's zoom in on the mu agonists, morphine, fentanyl. We need to clarify this idea of the ceiling effect.
This gets misunderstood all the time. For analgesia, for pain relief, mu agonists have no ceiling effect. You can, in theory, always give more to get more relief. But
There's a big but.
there's a huge clinical ceiling, and that's the adverse effects. Primarily, respiratory depression and sedation. So the nurse's job is to constantly titrate that dose to find that perfect balance maximum pain relief with side effects the patient can actually tolerate.
Then you have the tricky ones. The agonist-antagonists, like nalbuphine. They're useful sometimes, but can be really dangerous.
They are very tricky. They act as an agonist at one receptor, the kappa, which gives some pain relief, but as an antagonist at the mu receptor. And here's the giant safety alert. If your patient is on long-term mu opioids,
It's like for chronic pain.
exactly. If you give them an agonist-antagonist, it will knock the main opioid off the receptors and throw them into immediate severe pain and a profound withdrawal syndrome. You just have to avoid them in any opioid-dependent patient.
For post-op pain, PCA, patient-controlled analgesia, is still a gold standard, right?
Oh, it's strongly recommended. It puts the patient in control, which is where they should be. They can give themselves small, frequent doses within safe limits that the nurse sets.
So the nurse's role shifts a bit.
It does. Your job becomes titrating the pump's settings, adjusting that baseline dose up or down based on their pain schools, and just as importantly, their level of sedation. You're always chasing that balance.
What about the adjuvants, the co-analgesic agents, especially for something like neuropathic pain?
For neuropathic pain, anticonvulsants are first line, so we're talking about gabapentin and pregabalin. The key clinical pearl here is knowing their different timelines.
How so?
Pregabalin works much faster. You'll see its maximum benefit in about 2 weeks. But gabapentin needs a much, much longer titration. It could take up to 2 months to get the full effect. So you have to tell patients not to give up on it after a week or two. It just needs more time.
Good to know. And finally, let's be super clear on the difference between topical and transdermal routes. This is huge for safety.
It changes everything. Topical agents, like a lidocaine patch, are meant to work locally. The drug just sinks into the tissues right under the patch.
And you do 12 hours on, 12 off.
Right. But transdermal agents, like a fentanyl patch, are totally different. They're designed to be absorbed through the skin and into the systemic circulation. It's a systemic dose.
Which means they have a delayed onset.
Very delayed.
Right.
Which makes them completely wrong for acute or breakthrough pain. And the huge safety alert is heat. A fever, a heating pad, even a hot shower can dramatically speed up the absorption from a transdermal patch and risk a sudden, life-threatening overdose.
Okay, so when we are using opioids, we have to manage the side effects. What's the one adverse effect that patients never develop a tolerance to?
Opioid-induced constipation. It's the one. Patients get used to the nausea, the sedation. But the effect on the gut never goes away. So you have to be aggressive and prophylactic with a bowel regimen. Stool softener, laxative, the whole deal, right from the start.
The most feared side effect, though, is obviously sedation leading to respiratory depression. Who are the highest risk patients?
Age is a big one. Anyone 65 or older. Also, obesity, sleep apnea, any underlying lung disease, and that first 24 hours after surgery or after starting a new opioid, That's when you have to be hypervigilant.
So how do you assess for that? It's more than just counting respirations, isn't it?
So much more. You're checking the rate, depth, and regularity of their breathing, but more importantly, you're assessing their sedation level. A patient who is drowsy but easy to arouse is one thing. A patient who is difficult to arouse, who's snoring because their airway is partially obstructed, that's a huge red flag.
And a priority is.
The absolute nursing priority is to stop or reduce the opioid at the very first sign of advancing sedation. Don't wait for the respiratory rate to drop to 8. Act when the sedation deepens. That's how you prevent the crisis.
And if that crisis happens, we use naloxone. What's the critical safety fact about that drug?
It works fast, but it wears off fast. Its duration is only about an hour. Many opioids last much, much longer, so a patient can wake up after a dose of naloxone but then slip right back into respiratory depression an hour later. You have to monitor them closely and be ready to give more doses or even start an infusion.
Last thing in this chapter, and it's a big one for patient education, the difference between the normal physiological effects and actual substance use disorder.
Yes, tolerance and physical dependence are normal, expected responses. Tolerance just means you need a higher dose for the same effect. Physical dependence means your body has adapted and you'll have withdrawal symptoms if you stop suddenly.
But that's not addiction.
It is not addiction. Substance use disorder, or SUD, is defined by compulsive use and craving, despite negative consequences. They are totally different concepts, and we have to be clear about that with patients and families.
Okay, that's a great foundation. Let's switch gears to the science that underlies almost all of critical care. Fluid, electrolyte, and acid-base balance.
Back to the fundamentals.
We have to start with the physics. How does fluid actually move around the body?
It's all about finding balance, or equilibrium, and it's governed by two main processes. First is osmosis, which is the movement of water across a membrane. Water moves from an area with less stuff dissolved in it to an area with more stuff, trying to dilute it and even things out.
And diffusion is the movement of the stuff itself, the solutes.
Exactly. Diffusion is solutes, like sodium or potassium, moving from where there's a lot of them to where there's less, from high concentration to low. That's how we get nutrients into cells and waste out.
When we talk about where all this fluid lives, we focus on inside the cells, the ICF, and outside the ECF. But the amount of fluid in that interstitial space is pretty shocking.
It really is. Most of your body water is inside the cells.
Yeah.
But of the fluid outside the cells, the vast majority is in that interstitial space, the fluid that's just bathing the tissues. We're talking 11 to 12 liters in an average adult. The actual blood plasma volume is tiny in comparison, only about 3 liters.
Which makes the idea of a third space fluid shift so dangerous. That's fluid that's basically gone AWOL from the circulation.
It's completely out of play. It's left the blood vessels, but it's not in the cells either. It's trapped in a place like the abdominal cavity as the sites, or in the pleural space. So the patient can look swollen and edematous, but their blood pressure is dropping because they are functionally completely volume depleted.
A walking paradox.
It is, and you have to be careful because as they get better, all that fluid can shift back into the vessels very quickly and throw them into circulatory overload.
So how do we track all this? The kidney is the master regulator. We look at the BUN and creatinine ratio. What does a weird ratio tell us?
A normal ratio is about 10 to 1, but if you see a ratio greater than 20 to 1, that's a huge clue that you're looking at a fluid volume deficit.
Why is that?
Because when the kidneys sense low blood flow, they try to conserve water. As they do that, they reabsorb a lot of urea, the BUN, which makes its level in the blood go way up relative to creatinine. But it's critical to remember that creatinine is always the better, more accurate measure of actual kidney function because it's not reabsorbed like that.
Let's quickly review the hormonal controls, starting with the big one, the RAAS system.
Right, the renin-angiotensin-aldosterone system. This is the body's main volume control. Low perfusion triggers renin, which leads to angiotensin II, a powerful vasoconstrictor, and then angiotensin II triggers aldosterone.
And aldosterone tells the kidneys to hold on to salt and water.
Exactly. It makes the kidneys reabsorb sodium and water, which expands volume, but at the same time it promotes the excretion of potassium.
And working against that system, you have the natriuretic peptides, ANP and BMP.
Yep. They're released by the heart when it gets stretched by too much volume. They're basically the body's natural off switch for the RAAS. They promote sodium and water excretion natriuresis to get rid of that excess volume. And clinically, a high BNP level is a key marker for heart failure.
So when we're assessing for fluid volume deficit or hypovolemia, what's a better sign than skin turgor, especially in older adults?
In older adults, skin turgor can be really unreliable just due to aging. A much more valid indicator is tongue turgor. In FVD, the tongue actually looks smaller, and you'll see these distinct longitudinal furrows like little valleys running down it.
And what are the really late, dangerous signs we're looking for?
The neurological signs. As you get less and less blood flow to the brain, you'll see confusion, lethargy, and then delirium. We can never, ever write off new onset confusion in a dehydrated patient as just a normal part of aging. It's a sign of a hemodynamic crisis.
On the flip side, with fluid volume excess, or hypervolemia, the nursing alert is all about watching for circulatory overload when giving IV fluids.
Oh, this is a huge one. The minute you start pushing IV fluids, especially in someone with a bad heart, you risk drowning them from the inside out. You have to watch for rapid weight gain, a bounding pulse, JVD in the neck,
And listening to the lungs.
and listening to the lungs for a new cough, shortness of breath, and crackles. That means fluid is backing up into the lungs. You have to slow that infusion way down immediately.
All right, let's hit the big electrolyte crises, starting with hyponatremia, low sodium. Why is severe hyponatremia sometimes treated with something that sounds so dangerous, like hypertonic saline?
Because severe hyponatremia is often from having way too much water, which dilutes the sodium. This can make brain cells swell, leading to seizures or even death. So in a crisis, use hypertonic saline 3 or 5% sodium to rapidly pull that water out of the brain cells and reduce the swelling.
But the danger of fixing it too fast is terrifying.
It's one of the most feared complications in medicine. If you raise the sodium too quickly, you can cause an irreversible neurological condition called central pontine myelinolysis, or CPM. It destroys the myelin sheath in the brainstem.
So what's the goal then?
The goal is not to get the sodium back to normal. The goal is just to raise it enough to stop the seizures, usually up to about 125, and then you slow the correction way, way down.
Okay, now hyperkalemia, high potassium. This is the one that can kill you in minutes because of the heart. What are the ECG signs every nurse has to know?
High potassium messes with the heart's electrical system, risking VFib and arrest. The classic progression on an ECG is first these tall, peaked T waves. Then the PR interval gets longer, P waves disappear, and finally the QRS complex widens out. That's a sign of impending cardiac arrest.
And treatment is an emergency.
It's an emergency. You give IV calcium gluconate first. That doesn't lower the potassium, but it protects the heart muscle. Then you give insulin and dextrose to force the potassium back into the cells. And then you work on getting it out of the body with things like kyaxalate or dialysis.
And there's a common dietary pitfall here, right?
Yes. You have to warn patients who are on potassium-sparing diuretics like spironolactone to stay away from salt substitutes. A lot of those products are made with potassium chloride instead of sodium chloride, and they can cause life-threatening hyperkalemia.
Let's touch on calcium and magnesium. They're often linked. Why is magnesium so important for the others?
Because magnesium is a key cofactor for the pumps that regulate potassium and calcium. If a patient's magnesium is low, their kidneys can't hold on to potassium and calcium properly. You'll end up with hypokalemia and hypocalcemia that just won't get better no matter how much you replace until you fix the magnesium first.
So always check the mag level.
Always. But too much magnesium is also dangerous. It's a major CNS depressant. At high levels, you'll see loss of deep tendon reflexes and eventually respiratory depression.
Okay, let's tie this together with acid-base balance. For metabolic acidosis, low pH, low bicarb, what's the dangerous electrolyte shift that happens?
In an acidotic state, the body tries to buffer the excess hydrogen ions by pushing them into the cells. But to maintain electrical balance, for every hydrogen ion that goes in, a potassium ion has to come out,
Causing hyperkalemia.
causing a potentially lethal acute hyperkalemia. And the body's compensation for this is to start breathing really fast and deep Kussmaul breathing to blow off as much CO2, which is an acid, as possible.
And what about respiratory acidosis? That's a ventilation problem.
It is. The patient isn't breathing effectively, so they're retaining CO2. The treatment, then, is all about improving their ventilation, hydrating them to thin secretions, chest physiotherapy, deep breathing exercises.
And if they need to be put on a ventilator?
There's a huge safety alert. If a patient has chronic high CO2, their kidneys have compensated by holding on to a lot of bicarbonate. If you put them on a ventilator and drop their CO2 level really fast, you'll unmask that chronic bicarb excess and throw them into a severe metabolic alkalosis, which can cause seizures and deadly arrhythmias. You have to lower the CO2 slowly, gradually.
Good point. And just to wrap up this section, a quick review of IV complications. What's the key difference between phlebitis and infiltration?
Phlebitis is inflammation of the vein. It's going to be red, warm, and painful along the vein track. Infiltration is when the IV fluid leaks out of the vein into the tissue. That area will be swollen, pale, and cool to the touch.
And an IV pump can actually make infiltration worse.
It can. The pump works on pressure, and it will just keep pushing fluid into that tissue, causing more and more damage until a nurse physically assesses the site and shuts it off.
And for a hematoma, a bruise at the site.
Pull the fourth, apply light pressure, and then ice for the first 24 hours to reduce the swelling. Simple as that.
Okay, let's move into the real crisis zone. Shock, sepsis, and MODS. The definition of shock is simple, inadequate tissue perfusion. But the core nursing alert is that by the time the blood pressure drops, you are already way behind.
You are so far behind. The cellular damage from lack of oxygen has been happening for a while. That's why catching it in the compensatory stage is everything. It's the whole game.
So let's talk about that stage. The body is fighting back, pumping out catecholamines. What's the really subtle but critical sign a nurse needs to spot?
You have to look for a narrowing of the pulse pressure. Pulse pressure is just the systolic minus the diastolic. In this stage, the body vasoconstricts like crazy to keep blood flowing to vital organs, and that makes the diastolic pressure shoot up.
So you might see a blood pressure of like 100/80.
Exactly, a pulse pressure of 20. If you see that, especially with other subtle signs like the patient is a little more anxious or restless, you have to be thinking shock.
And if that compensation fails, we enter the progressive stage. This is where things really start to fall apart at the micro level.
They do. The body can't maintain that vasoconstriction anymore. Lactic acid is building up everywhere from anaerobic metabolism. And the big thing that happens is a massive increase in capillary permeability. Fluid just starts leaking out of the blood vessels everywhere,
Causing that third spacing we talked about.
causing profound, widespread edema, which makes the circulating volume even lower and organ perfusion even worse. It's a vicious cycle.
And then the irreversible stage.
At that point, the damage is done. The organs are failing, cells are dying, and nothing we do is going to reverse it. And at that point, our entire focus has to shift very openly and honestly with the family to palliative care. Comfort, dignity, and symptom management are the only goals left.
Now, let's talk about distributive shock. The problem here isn't a lack of fluid, it's a plumbing problem. Massive vasodilation.
That's the perfect way to describe it. The pipes have gotten too big for the fluid inside them. This massive vasodilation causes blood to pool in the periphery, so venous return to the heart plummets, and cardiac output tanks.
Of the different types, neurogenic shock is the really weird one. It breaks all the rules for what shock should look like.
It's the total outlier. It's usually from a spinal cord injury that knocks out the sympathetic nervous system. So with the parasympathetic system running unchecked, instead of the tachycardia you'd expect, the patient presents with hypotension and bradycardia, a low blood pressure and a slow heart rate.
And their skin.
And because they can't vasoconstrict, their skin is dry and warm, not cool and clammy like in every other type of shock. It's a very distinct clinical picture.
Okay, now for the big one. Septic shock. It's defined by these profound circulatory and metabolic problems.
Right.
This is where we use tools like the SOFA score, right?
We do. The SOFA score helps us quantify just how bad the organ dysfunction is. But clinically, septic shock is defined as needing vasopressors to keep the mean arterial pressure, or MAP, at 65 or higher, and having a high lactate level even after you've given them plenty of fluid.
So what are the absolute time is tissue priorities in the sepsis bundle?
Number one is fluids. An aggressive fluid challenge of at least 30 milliliters per kilogram of crystalloids in the first 30 minutes, that's non-negotiable.
And antibiotics.
Number two is broad-spectrum antibiotics within 1 hour of recognizing sepsis. But, and this is critical, you have to get your blood cultures before you hang that first dose.
And if the blood pressure is still low after fluids,
Then you start vasopressors, usually norepinephrine, to squeeze the vessels and get that MAP up to the target of 65.
if we can't stop this cycle, the patient can progress to MODS, Multiple Organ Dysfunction Syndrome. What's driving that cascade of failure?
It's just uncontrolled systemic inflammation. This cytokine storm damages the lining of blood vessels everywhere, causing massive capillary leak, widespread tiny blood clots, and just a total failure of oxygen delivery to all the organs. The lungs go, then the kidneys, then the liver, and the prognosis gets exponentially worse with every organ that fails.
Okay, we have to acknowledge that even for the people who survive this, there's a long road ahead. We call it post-intensive care syndrome, or PICS.
PICS is a huge deal. It's this combination of physical, cognitive, and mental health problems that stick around long after they leave the ICU. They have profound muscle weakness, memory problems, anxiety, PTSD. The nurse's role in preventing it starts in the ICU managing delirium, protecting sleep, and pushing for early mobility, getting them out of bed as soon as humanly possible.
Such an important point. Okay, let's shift gears completely now to the long-term, complex journey of cancer care. Chapter 12 starts with the basic difference between a malignant and a benign tumor.
And the difference is all about the potential for destruction. A benign tumor grows, but it stays put. A malignant tumor, cancer, has the ability to invade its neighbors, grow its own blood supply, and critically metastasize to distant parts of the body. That's what makes it so deadly.
The process of cancer development, carcinogenesis, is described as a battle between cellular on and off switches.
It really is. You have proto-oncogenes, which are the normal on switches for cell growth. When they mutate, they become hyperactive oncogenes that tell the cell to divide.
And the off switches.
Those are the cancer suppressor genes. They're the brakes. They're supposed to halt the cell cycle and trigger cell death if a cell gets damaged. When you lose your brakes, those damaged cells just keep multiplying.
So knowing that, what are the key primary prevention strategies nurses need to teach?
Primary prevention is all about reducing risk. So that means lifestyle changes. Avoiding carcinogens like tobacco, limiting alcohol, cutting back on red and processed meats, and staying physically active. The recommendation is at least 150 minutes of moderate exercise a week.
And secondary prevention is all about screening, finding it early.
Exactly. Following the established guidelines. Mammograms for breast cancer, colonoscopies for colorectal cancer, and for specific high-risk groups like heavy smokers, annual low-dose CT scans of the chest.
Once a cancer is found, it's staged using the TNM system.
Yeah.
How does that staging then guide the whole treatment plan?
The TNM system, tumor size, node involvement, metastasis, tells you the anatomical extent of the disease. And that's vital because it determines the goal. Is the goal cure, total eradication? Is it control, keeping it at bay for as long as possible? Or is it purely palliation, just managing symptoms? A stage 4 diagnosis almost always means the goal is control or palliation.
Treatment often begins with surgery.
It's the oldest and still most common treatment. It can be diagnostic, like a biopsy, curative, where you take out the tumor and a clean margin of tissue around it, or even prophylactic, like removing the breasts in someone with a high-risk BRCA mutation before cancer ever develops.
For radiation therapy, a new technology is all about precision, right? Sparing healthy tissue.
It's a massive leap forward. Techniques like IMRT intensity modulated radiation therapy use computers to shape dozens of tiny radiation beams to match the exact 3D contour of the tumor. You can deliver a much higher, more effective dose to the cancer while sparing critical structures right next to it, like the spinal cord.
And then there's brachytherapy, internal radiation. This puts the nurse under some very strict safety rules.
That's because with brachytherapy, the patient themselves is emitting radiation. So nursing care comes down to 3 principles: time, distance, and shielding. Limit your time in the room, keep your distance as much as possible, and use lead shields or aprons. It's a totally different way of providing care.
Moving to systemic drugs, let's talk chemotherapy. What are the 2 biggest, most acute risks a nurse has to watch for during the infusion itself?
You have to be on high alert for 2 things. First, hypersensitivity reactions, or HSRs. They can be anything from a mild rash to full-blown anaphylactic shock. Second is extravasation.
That's when the drug leaks out of the vein.
And if it's a vesicant, a blistering agent, it's a true medical emergency. It can destroy the tissue, causing permanent necrosis. You have to know the specific antidote for that drug and have it right at the bedside ready to go.
And finally, the game changer. Immunotherapy, specifically checkpoint inhibitors. How do these work differently?
It's a totally different philosophy. Chemo kills the cancer cell directly. Immunotherapy unleashes the patient's own immune system to do the job. Checkpoint inhibitors block the off switches, like PD-1, that cancer cells use to hide from T cells. You're essentially taking the brakes off the immune system.
Which leads to a very unique set of side effects.
It does. We call them immune-related adverse events, or IRAEs. Because you've supercharged the immune system, it can start attacking healthy organs. You can see severe colitis, pneumonitis in the lungs, hepatitis, really any antibodies you can think of, and they often require high-dose steroids to calm that immune response back down.
So managing those toxicities becomes the nurse's primary job. Let's start with the most critical one, infection risk from neutropenia.
Neutropenia, a low white blood cell count, is an immediate life-threatening risk. The nursing care is strict. Meticulous hand hygiene, no rectal temperatures or suppositories. And any fever, even a low-grade one in a neutropenic patient, is an oncologic emergency. You get blood cultures and start broad-spectrum antibiotics immediately, often without even knowing what the infection is yet.
Another miserable side effect is stomatitis, those painful sores in the mouth.
They can be debilitating. The key is meticulous oral hygiene with a soft brush and avoiding anything irritating, especially commercial mouthwashes with alcohol. For patients getting really high-dose chemo, there's a growth factor called palifermin that can help the mucosal cells heal faster and reduce the severity.
Then there's the complex wasting syndrome, cancer-related anorexia, cachexia, or ACS.
And ECS is so much more than just not eating enough. It's an inflammatory metabolic process that causes profound muscle wasting and fatigue, even if the patient is taking in calories. Management has to be multifaceted. Nutritional counseling, appetite stimulants, and really importantly, encouraging exercise, which is proven to help preserve muscle mass.
And the most common side effect of all, cancer-related fatigue.
It's this overwhelming exhaustion that's not related to activity and isn't relieved by rest. The nurse's job is to play detective. Is it pain, anemia, depression? But counterintuitively, the single best intervention we have for managing that fatigue is encouraging the patient to engage in moderate physical activity. It really does help.
Let's cover two oncologic emergencies that need immediate recognition. Tumor lysis syndrome, TLS, and spinal cord compression. What is TLS?
TLS happens when chemotherapy works too well, too fast. A massive number of cancer cells die all at once and dump their contents into the bloodstream. This creates an electrolyte nightmare.
What do you see?
You see sky-high hyperkalemia, high phosphate, which causes low calcium, and a ton of uric acid, which can cause acute kidney failure.
And the treatment is?
Aggressive hydration, starting even before the chemo, to flush the kidneys. And we give drugs like allopurinol or rasburicase to deal with that massive uric acid load.
And spinal cord compression.
This is a neurological emergency, usually from a tumor pressing on the spinal cord. It presents as back pain. The reason it's an emergency is because if it's not treated quickly, it can cause permanent paralysis. The nursing priority is constant, meticulous neurochecks motor, sensation, bladder function, and getting them ready for emergent radiation or surgery.
Okay, we're at our last section. Let's conclude our deep dive with the most profound part of care: palliative and end-of-life support. We have to start by clarifying the difference between palliative care and hospice care.
Yes, this is so important. Palliative care is all about symptom management and supporting quality of life for anyone with a serious illness. And this is the key. It can be given right alongside curative treatment. You can get chemo and palliative care at the same time.
And hospice care is a very specific type of palliative care.
Exactly. Hospice is for patients who have decided to stop curative treatment and have a prognosis of 6 months or less. The goal shifts completely from extending life to maximizing the quality of the life that's lived.
A necessary shift, since the way people die has changed so much.
It has. We've moved from sudden deaths to these long, chronic, degenerative illnesses that can go on for years.
The sources really emphasize that communication in this field is a core skill, something that can be taught.
Oh, absolutely. It's not just about being nice. It's about having structured conversations, using techniques like ask, tell, ask to figure out what the patient and family truly understand and what their goals are. This is the foundation for good advanced care planning, or ACP.
And ACP is where we document those wishes. What are the two main documents?
You have an advance directive or a living will, which spells out what specific treatments a person would or would not want, like a ventilator or feeding tubes. And then you have a proxy directive, which is where you appoint a person, your durable power attorney for healthcare, to make decisions for you if you can't.
Both are so important for honoring autonomy.
Absolutely.
And when we talk about grief, we've moved beyond the old linear stage models to something called the dual process model.
Which is so much more realistic. It recognizes that when you're grieving, you oscillate. You swing back and forth between loss-oriented things, crying, remembering, feeling the sadness, and restoration-oriented things, paying the bills, going back to work, learning to live in this new reality. And that swinging back and forth is normal and healthy.
When we manage symptoms near death, a lot of it is about anticipatory planning. What does that look like in practice?
It means getting ahead of the problems. A common tool is the comfort kit, or an emergency symptom pack that we leave in the home. It has pre-prescribed small doses of medications for things like pain, anxiety, nausea, or shortness of breath, so the family has what they need at 2 in the morning and doesn't have to panic.
Let's talk about a really difficult symptom, impaired secretions, the so-called death rattle. It's often much harder on the family than the patient.
It is. It happens because the patient is too weak to clear their own secretions. The first thing a nurse has to do is reassure the family that this sound is usually not distressing to the patient, who is often deeply unconscious.
So what do you do?
You reposition them, turning them on their side. And you can give anticholinergic medications like atropine drops to help dry up the secretions. The one thing you don't do is deep suctioning. It's traumatic and usually doesn't help.
Delirium is another really common and distressing symptom.
It is. The key is to first look for and treat any reversible causes. Is their pain out of control? Are they constipated? Is there some spiritual distress? You try non-drug approaches first, like creating a calm environment, before you reach for medications.
And what about the most complex ethical challenge? Palliative sedation. This is a true last resort.
The absolute last resort. This is only for a patient with refractory symptom suffering that cannot be relieved by any other means. It involves using medications to lower their level of consciousness enough to relieve that suffering. It requires clear consent beforehand, a full team discussion, and meticulous documentation that the intent is to relieve suffering, not to hasten death.
And the most controversial choice of all, voluntary stopping of eating and drinking, or VSED.
VSED is a profound choice. The patient has to have full decision-making capacity. It's a long process. Death usually occurs in 10 to 14 days. And the nurse's role is intensive, providing expert symptom management, especially for dry mouth, and supporting the family through a very, very difficult time.
The nurse's role also extends to the spiritual side of things, which is broader than just religion.
So much broader. Spirituality is about meaning, purpose, hope, connection. We can use tools like the FLACC assessment to gently open up that conversation, exploring a patient's faith, its importance, their community, and how we can address their needs.
And finally, we support the family through bereavement.
That support starts long before the death, helping them with anticipatory grief. And afterwards, the nurse needs to be aware of the signs of complicated grief, that persistent, debilitating sadness that just isn't getting better and may need a referral for professional help.
Okay, let's unpack this. What an immense journey we have just taken, spanning 5 critical domains of med-surg care. We went from the microscopic, cellular shifts causing hyperkalemia to these huge macroscopic ethical decisions about life and death.
The synthesis, I think, is really clear. The core challenge of nursing today is this masterful integration of really sophisticated clinical knowledge. Applying the Sepsis Bundle, understanding the risk of CPM, using SOFA scores, with the compassionate human side of care, honoring the patient's subjective experience, their individual values.
It demands total clinical vigilance and judgment.
It does. Which leads us to our final provocative thought for you to consider. We talked so much about the need for nurses to identify these subtle, life-threatening changes, that narrowing pulse pressure and shock, the slight confusion of hyponatremia, the deepening sedation before respiratory arrest. These are signals that show up long before a lab test confirms the disaster.
So the question is,
what systems, what training, or what personal commitment can we foster to ensure that nurses always, always trust their keen clinical judgment in those critical moments?
a challenge well worth taking on. Thank you for joining us for this deep dive into critical med-surg care.
Until next time.